Hello, I'm Dr. Pipitius Kwa. My friends know me as Pip, and I'm a consultant in respiratory medicine and intensive care medicine at Woodlands Health in Singapore. Welcome to my first video tutorial series on bronchial branch tracing, otherwise known as airway mapping. So what is bronchial branch tracing and how is it useful? I would like you to imagine that you're an intrepid adventurer like Indiana Jones, and you have recently come into possession of a map which leads to a mysterious hidden treasure. Using this map, you have to plan a route from your camp to the location of the treasure. However, the safest route involves navigating a complex network of tunnels, and one wrong turn could lead to death. How can you map the route out? And how do you know which turn to take when you see it? The problem is, when you're inside a network of tunnels, it looks nothing like the route on the map. And whenever we interpret a map, it is important to take note of the route and the orientation of the map to get our correct bearings. In peripheral bronchoscopy, what we are doing is we are driving into the airways, which are essentially a series of tunnels. And these tunnels can lead us to a treasure, such as a lung nodule, reflected in this CT and marked with an X. What we want to be able to do is to draw a path through the airways exactly as we would see them, so that we can find our way to the target airway leading to the peripheral pulmonary lesion or nodule. And of course, this tunnel looks remarkably similar to the carina we see on bronchoscopy. So what is bronchial branch tracing or airway mapping? Bronchial branch tracing is the art of converting a CT scan into a 2D hand-drawn map of the airways. And this allows us to navigate with a bronchoscope to the airway leading to the peripheral pulmonary lesion. Why should we learn bronchial branch tracing? Well, whilst automated methods such as virtual bronchoscopy, electromagnetic navigational bronchoscopy, and robot-assisted bronchoscopy exist, they are still unable to supplant the accuracy of mapping achieved through manual CT reading. Understanding airway mapping also improves our CT reading and appreciation of endobronchial obstructions or tumors, and increases our understanding of bronchial anatomy and anatomical variants during bronchoscopy. This also allows us to perform more targeted sampling for bronchial alveolar lavage or transbronchial lung biopsies in other diseases such as diffuse parenchymal lung disease or interstitial lung disease. Now, I would be remiss not to mention the original inventor of the bronchial branch tracing technique, Professor Noriaki Kurimoto. I would strongly recommend all of you to read his book on bronchial branch tracing. The method I described in this video requires use of the axial, sagittal, and coronal reconstructions, which is a modified version of its original technique of using axial CT views. Now, before we can correlate the CT scans to the images we will see on bronchoscopy, it is important to understand the differences in the images acquired on CT and bronchoscopy. The CT scan is acquired in a caudal to cranial direction, as illustrated by the arrow on the left, whereas a bronchoscopy is performed in a cranial to caudal direction. Whenever we interpret a map, which in this case is the CT scan, it is important to take note of the route and the orientation of the map to get our correct bearings. Likewise, it is crucial to orientate the CT scan such that it mimics the orientation of bronchoscopy. This can involve flipping the CT horizontally so that the left and the right side will match, rotating the CT scan, or both. I will now proceed to describe some fundamental concepts of airway mapping. The first concept is that all airways travel in one of three general directions, which can be in a cranial caudal, anterior posterior, or medial lateral direction. Let me explain. As mentioned, fundamentally, all airways can only take one of three directions. This can be in the axial plane, as illustrated by the red tube, which travels in a caudal to cranial direction. The coronal plane, illustrated by the yellow tube, where the airway travels in the anterior to posterior direction. Or the sagittal plane, where the airway travels in a medial to lateral direction. The second key concept is that airways are essentially a series of linked tubes. The airways branch mostly dichotomously and travel in different directions, but all airways are connected in series. This means that ultimately, the path to any nodule is linear. As mentioned, even though the airway may seem like a complicated network of tunnels, every path through the airway is linear as the airways are lined up in series. If the X were to represent a nodule, the path that we take from the vocal cords to the airway, as you can see, even though it may traverse a complicated network of branches, is essentially a straight and linear path. The third key concept is that tubes, when viewed end-on, appear as circles. The best way to help you visualize this is to take two straws, such as these two straws I have in my hands over here. Now if you were to place them side by side and look at them, they appear as two horizontal tubes. But if you were to view them end-on, like so, they will appear as circles. Now, during bronchoscopy, when we are moving inside the airways, we are essentially viewing a series of circles, just like the entrances within a tunnel. As you can see, if all we see are holes, all we have to do is just to draw the holes of the same size and the same branching angle. So on the CT scan on the left, if you were to see two holes stacked up like this, all we would need to do is to draw a circle and draw the branching angle exactly as illustrated. This brings us to the fourth key concept, which is to find the correct CT reconstruction to use as the map. This is achieved by finding the correct CT reconstruction in which the airways appear as circles, which is based on the direction of travelling of the airways. Look first at the direction in which the airway travels. If it travels in the cranial to caudal direction, use the axial view. If it travels in an anterior to posterior direction, use the coronal view. And if it travels in the medial to lateral direction, use the sagittal view. Just like we need to orientate a map to north, south, east, and west, we will also need to orientate our CT scan such that anterior, posterior, medial, lateral, and cranial caudal orientations are aligned with the bronchoscopic image. In order for us to correlate the images we see on bronchoscopy, it would be helpful to review the movements we take during bronchoscopy. Now we start by inserting the scope through the vocal cords, and we advance the scope caudally. As we go caudally, we end up at the main carina, and we see the left mainstem bronchus as well as the right mainstem bronchus. From there, we then take the scope and turn it to the right, and we advance the scope cranially to view the right upper lobe, which has the branches of the apical, the posterior as well as the anterior segments. Now to enter the bronchus intermedius from the main carina, we turn right and go caudally, and we see the middle lobe and the branches of the lower lobe. To view the segments of the left lung, we go back to the carina, and we turn left to enter the left mainstem bronchus, and we proceed cranially, where we will see the left upper division comprising of the branches of the upper lobe as well as the lingular segments. To enter the lower lobe, returning back to the main carina, we turn left and go caudally, where we will see the branches of the lower lobe. It is crucial to understand the movements made by the bronchoscope, as we will need to mirror these movements in order to orientate the CT scan. When we perform bronchoscopy, as mentioned, we are moving from a cranial to caudal direction. When we go through the vocal cords, we turn the scope to the right, and then we proceed downwards in order to enter the bronchus intermedius. If we want to view the right bronchus intermedius, since the airways are traveling in a cranial to caudal direction, this is best viewed on the axial CT, as shown here. We then have to flip the CT scan horizontally so that the right side of the CT image will correlate with the right side of our bronchoscopic image, as shown in the image here. Now, since the bronchoscope makes a turn to the right, this requires our CT image to turn to the left. This is because the CT scan, as you recall, is taken from a caudal to cranial direction. So if we were to rotate the CT scan to the left, we'll be left with this image of the CT. We can then draw a series of circles to transcribe the CT image to the image we expect to see on bronchoscopy. What this means is that by drawing a series of circles, we can draw the angle of the branching of the middle lobe and the lower lobe exactly as we see it on the CT scan. And that by using the CT, we can draw a map of the bronchoscopic view by following the exact branching angles and size of the holes. And we can see that the middle lobe as well as the lower lobe and the branching corresponds exactly as what we would expect to see with the bronchoscopic image. Now, to recap the 5 key concepts, the first concept is that all airways travel in one of 3 general directions, which can be in a cranial caudal, anterior posterior, or medial lateral direction. Airways are a series of linked tubes, meaning that the path to any nodule is linear. And tubes, when viewed end-on, appear as circles. We can then choose the appropriate correct CT reconstruction and orientate the scan to align to the bronchoscopic image. We can then move on to perform airway mapping or bronchial branch tracing through a step-by-step approach. The first of which is to locate the lung segment in which the lesion is located, to find the appropriate CT reconstruction, to orientate the image, and then to proceed to match the direction of our CT scrolling to the expected movement of our bronchoscope. We can then draw the branching angles exactly as seen and take care to size the bronchi and the angles accurately. It is important to know that you can practice airway mapping even by using a normal CT scan. This starts with learning to select the correct scan and orientating the scan appropriately to match the bronchoscopic view. You can locate a lung segment, select the correct CT orientation, then flip or rotate the CT scan and draw the expected bronchoscopic image based on the CT. In this slide, I have also detailed down some preferred views depending on where the lesion is located. The views to be used should be intuitive based on the direction of airway travel. You may find that in some cases, concurrent use of multiple views is required for airway mapping. We will now move on to some case examples so that we can put into practice what we have learned so far about airway mapping. In this first case, the nodule of interest is located in the right upper lobe. As we scroll through the CT scan, we will see that there's a nodule of interest located in the right upper lobe. Going back to the nodule of interest, I will highlight it with a red marker as indicated over here. How can we then draw a path to this nodule? Recalling the movement of our bronchoscope, as we enter from the main carina, what we have to do is to proceed with our bronchoscope, turn right, and move cranially to enter the right upper lobe. This means that to correlate to the CT image, the best reconstruction would be the axial CT. And because the bronchoscope makes a turn to the right, the CT image will need to turn to the left in order to match the bronchoscopic orientation. I will now play through the axial CT video and show you the rotation of the CT. The CT is rotated to the left. The lesion is located, and we zoom into the airway of interest. And we can see now the right upper lobe branching, going up, branching further, and going into the lesion. I would now encourage you to draw along with me as we look at this axial CT of a nodule in the right upper lobe. I will first play through the CT and show you how we rotate the CT to the left. We move down to the target airway of interest, which is here, and we look for the right upper lobe, and we are scrolling in a caudal to cranial direction. It is usually helpful to play through the CT once to be able to determine if there's an airway which leads to the nodule of interest. As I scroll forward and back, you can see that there's an airway which is entering the nodule. We can now proceed to draw an airway map. Please feel free to grab a piece of paper and draw along with me. We start by drawing a simple circle. What we do next is we look back and reference the CT to look for the branching angles which appear. From the right main stem bronchus, if you look closely over here, a branch, which is the posterior segment of the upper lobe or RB2, appears. This can be indicated by drawing the spur at exactly the angle as we see it over here, in this direction. If we were to scroll back on the CT, we can see that the hole on the left, which is indicated by this, splits into a hole superiorly. Hence, we know that there's an inferior hole here, which is the tube below it, and a superior hole, which is the tube above it. We then proceed to follow this hole, which is of course the apical segment of the right upper lobe. And as we scroll forward, we will see that it splits into two at this point over here, up and down, and we should draw the angles as such, with the same branching angle as seen over here. So if we were to draw that, it will appear like this. Subsequently, as we continue to scroll on in the CT, taking care to look at it again, we can see that it is the hole on top, which very subtly further splits into a left and right hole over here, and we can draw the angles as such. And of course, the left hole, apologies, is the one which leads into the nodule. Now, of course, I have a nicer image which was previously prepared, and I'll show it to you in the next slide. Now, I have a nicer map of the previously drawn map. And now we can reference the bronchoscopic images which were captured. We can see that indeed there's a branching angle here, over here, which separates the posterior as well as the apical and the anterior segments of the right upper lobe. And clearly, based on our airway map, we should be entering into the apical segment, which is indicated by the arrow here. When we move into the apical segment, we can then clearly see the next branching angle indicated over here, as we have drawn on our airway map. And already you can see the subsequent branching angle over here, which correlates to our airway map, and that indicates to us that the target airway of interest is this hole on the left, as indicated by the arrow shown. We then proceeded to insert a radial EBUS probe with a guide sheath into the target airway, and we were able to find a concentric image on the radial ultrasound, as shown in the image on the right. The histology for this patient revealed well-differentiated neuroendocrine carcinoma, which was positive for synaptophysin and chromogranin. Thank you very much for tuning in, and I hope you have enjoyed the first video of this tutorial series. Please do like and subscribe to my YouTube channel, where I will be releasing further case examples which you can use to practice your airway mapping. Thank you.